Good day, everyone. My name is Dr. Jim Augustine. I'm an emergency physician, and I now serve as your Associate Medical Director for Greater Naples Fire District. I live in Lely. Thank goodness for 23s. They were in the neighborhood yesterday. And I very much appreciate the opportunity to work with the department. I have a long history of service. It was 40 years ago when I signed on to the fire service in a suburb of Dayton, Ohio. Did my fire training in 1982, became an EMT a year later. Served with departments up there for many years. Then Atlanta, Georgia, and medical director for Atlanta Fire and for the Airport Fire Department. Assistant fire chief there, and then assistant fire chief in Washington, D.C. with D.C. Fire. And medical director for them, and then unfortunately I know this system too well. I get very sick with H1N1 pneumonia and couldn't recover, and moved to Naples, Florida. So I've been here for a few years, and I continue to serve with departments that I've had a long history with. And what's really important to me is how we serve our communities and how we serve each other. Those are the two basics. I've written a lot in the literature. I had a series of articles that ran for 12 years in the journal EMS, and then in EMS World as it transitioned across. And it was always about, serving well, keeping our members healthy for a healthy retirement, and customer service. I lectured a lot with Chief Brunacini from Phoenix and continue to carry on the heritage. In a couple weeks I go to the Wing Spread Conference where I'll serve as a keynote speaker there about what the fire service needs to look like over the next 20 to 25 years. And it's all about service, and it's about all hazards, and it is about what our community needs, and we have to be there to serve that. So. Too much about me, but I want you to know how important I feel our industry is in our communities and in our society. And we're in COVID times, and this is the wave that has come. It's been called the pandemic of the unvaccinated. That's what we're finding. A timely message is, if you haven't had the vaccine yet, if your family members who are eligible haven't had the vaccine yet, it's still a great time to take it. We've had hundreds of millions of doses of the vaccine given. It's very safe. Myself and my family members have all had the vaccine, and we have avoided the infection since the vaccine. Many of you know that my son is also a firefighter, a battalion chief, and paramedic. His father-in-law, who's another firefighter, that I worked with for 30 years, contracted COVID in November and died of it. Healthy, thin, 52-year-old fire lieutenant got overwhelming COVID and died. Left two high school sons, his daughter, who's obviously married to my son. My son got very sick with it too. 10 other members of the department got sick with it. It's no fun an experience. A couple of those people have the long haulers version of COVID, and vaccines are there. And remember about vaccines, you all are protected every day, and you don't think about things that were scourges in my early days. My birth time, we still had smallpox on the planet. I have the big old scar on my arm from getting a smallpox vaccination before I remembered it. I was the generation that still had polio, which was a horrible respiratory disease that also left people with terrible paralysis if it didn't kill them. So a respiratory spread much like coronavirus, with terrible effects on kids and a high death rate amongst children, but also amongst olders. And in an area near me, in Cincinnati, Ohio, they developed the initial vaccine, which was a shot, and then converted it over to a sugar cube. And now we don't even think about polio anymore. In the fire service, as I entered, the scourge at the time was hepatitis B, which our members and people I work with in the emergency department got sick of from blood exposures. We developed the hepatitis B vaccine. Now everybody in the industry gets hepatitis B. We don't even think about hepatitis B anymore. That's where we are at the coronavirus. 20-year development pathway for the coronavirus vaccines, just so you all are aware. The original work on coronavirus vaccines was in SARS, 2003, 2004. They were using mRNA technology that had been developed around the turn of the century for other diseases. They converted it over to the original SARS, and then when SARS went away, they didn't have to do full-time development but continued to work on coronavirus vaccinations. And then when COVID-19 came around, they cranked up the research machinery, tweaked the vaccine for COVID-19. So anybody who says these vaccines were just developed, that's not true, completely untrue. The old adenovirus vector vaccine, so that's Johnson & Johnson, AstraZeneca, another 25, 30-year-old technology tweaked to get to the COVID coverage. So these are old technologies applied to COVID. Fortunate for us, we have now prevented probably tens of millions of deaths from COVID because of the new vaccine programs. We've made a large part of our society safe again out in the community. But for those that haven't been vaccinated, still a big risk. They're still dying in the hospitals. There's occasional breakthrough infections in those who are vaccinated. They have not been serious other than in people with impaired immune systems and other serious health problems. So that's where we are with COVID now. We're back at the point where we're in masks in public settings and still universal precautions in dealing with patients. And every day now listening to the status F calls going out in the community here. So my introduction to the department, thanks to Chief Sapp, thanks to Dennis, Division Chief Saro, who is wrapping me in. And I'll be part of the education program from here on. Typically I do these in person, but because of circumstances now, I'll do some taped ones and give them to you with handouts. I always try to think like I'm in the field, and I've spent now 40 years, engines, ladders. I ran a lot with Squad 4, which is the heavy rescue in Atlanta. I still take calls all the time. That's really important to me. I'm there to assist people who are doing their jobs as they do every day, and to pick up more teaching material that I can share with others. So I love doing scene work, and my commitment to you is to keep things at scene level and not talk about emergency department care and what happens down the line. What we do is really important, and so today's presentation is about introduction to clinical priorities. We have very important all hazards responsibilities to our citizens and to each other, and we have really important roles to be prepared for any kind of hazard that comes down the line. Our customers, the people that we serve, also expect us to be really good at service. So not just taking care of medical needs, doing great assessments and treatment where needed, and organizing transport, but taking care of the other things that are important to them. Their belongings and their family and their pets and getting them off the roadway, etc. So can't forget all of those elements. Today's presentation about the medical side of what we do begins with what always compels us in healthcare system, which is the first responsibility we have is don't harm the patient. Don't do anything that puts them at greater risk. Evaluate them for an emergency. Treat any emergencies that you find. That's our responsibility, our legal responsibility. And then position them for transportation with our transport agency. Positioning the patient is always where I start, and there's a lot of times we get there and people are in the wrong position for whatever's going on with them. And so flattening everybody out and putting them on a backboard, we've known for a long time is not the right thing to do. And in particular for diseases that involve shortness of breath, things going on up here, much better position for patients to be in is upright. And so we talk about the very first thing is don't hurt the patient by slamming them down on a backboard and tying them down there. Airways, so in the medical care system, it's still the ABC. So protecting airway, really, really important. How are they breathing and what position can they breathe best in? And then we get to circulation, and then we get to disability, and then we get to exposure of hazards. Our original responsibilities to the patient, but as things are occurring, don't forget to protect the people around. And so if you walk into an environment and find that there's big hazard, we got to clear everybody out so that we don't have additional victims. If there's bleeding going on and somebody's looking at it and getting really lightheaded, time to get them out of the way and sit them down so the next thing they're not on the floor bleeding as well. Not that that's happened to me dozens of times in the past, but those are the kind of things that you think through real quickly as an experienced rescuer. And from the very beginning, people don't care how much you know until they know how much you care. That's really good training, really good practice. You got to show them that you care about them, and every opportunity that you have to show them how much you care, then you can focus on how to care for them to get them better. Our critical actions that we take in the first couple minutes, I wrote a little list here. It's as simple as things like somebody who today you get a call for who was putting gas in their car and the gasoline sprayed up into their eyes. You only get one set of eyes, you only get two corneas, and chemicals that get in the eye can leach through and damage the corneas really quickly. One of the more impressive things that we do immediately in somebody who has, for example, gotten their eyes contaminated with something is we forget about the vital signs and we focus right away on cleaning their eyes. So what a very simple way to begin my lecture about talking about priorities is, at the Atlanta airport, all the fueling of planes was done overhead. So they had underground piping, so the fuel's running at them, and they always had to fuel planes from underneath. In doing so, if they didn't make an exact connection, it would spray gas in their eyes. Many of the employees knew how to deal with the spray themselves, but for the bad ones, we would get called fairly quickly, and our crews, had a routine of being able to pull up to the scene, have their irrigation equipment ready for an eye irrigation, not worried about blood pressure and pulse rate and the name of the patient until it was necessary to help do care, and they would be hosing down the eyes quickly to get the jet fuel, which is kind of corrosive, out of their eyes. Same thing happened in industrial settings, and where I grew up in Dayton, Ohio, we did a lot of hazmat, and I spent a lot of my career in hazmat. Sprinkled through a lot of my teachings over the next couple of years, you'll hear a lot of hazmat because that was one of our big life threats to people. Healthy workers who got involved in something, whether it's getting their hands in a press or printing rollers or industrial processes that involve chemicals. Easy stuff like industrial acids through to hydrogen fluoride and cyanide, and people dunked in cyanide tanks, etc. So in industrial acid solutions in the eye, which we would have, you have seconds to minutes to get that stuff out of the eyes. So immediately action plans in place, not worried about extraneous stuff, and something as simple as cleaning eyes prevent a lifetime of disability for individuals we deal with. Other things we do immediately, open an airway, treat anaphylaxis, and the treatment for anaphylaxis is only one chemical, and that is epinephrine. For the paramedics, Benadryl is not a life-saving chemical, not a life-saving drug. The only life-saving drug in anaphylaxis is epi. We're in season now for insect stings, and then a lot of people exposed to nuts and penicillin and shrimp and shellfish and other things they're allergic to, airway swelling, extensive hives, going into shock, some combination of those things. Intramuscular epinephrine in the upper arm or in the thigh, life-saving. You have minutes to give it to prevent a perfectly healthy person from dying, and it's our responsibility to get that aboard right away. Again, this is a situation where you recognize what is going on, you got a history, you got the note through dispatch about what had happened. That should be prepared in your hands, ready to go to take care of the patient. As soon as you recognize that patient's in trouble, the epinephrine has to go in. We have a case where a paramedic just kind of wasn't keeping their priorities straight. Had a girl who was at a restaurant, ate a food accidentally that she was allergic to, began to develop symptoms. She usually carries an EpiPen, but because of the shortage of EpiPen, she doesn't have it. Her friends don't quite know what to do right now, but somebody on the restaurant staff calls 911. We get there. Didn't look like she was in big trouble, so let's just transport her to the hospital. And en route to the hospital, she just crashes. And the epi's not aboard, and an IV is in place, and they gave 25 milligrams of Benadryl. She was in cardiac arrest by the time they hit the ED doors. She was resuscitated, but with significant brain injury as a result of that, and a case, that's got a bad outcome that we could have avoided. And I want to make you aware, epinephrine is the medicine for anaphylactic reactions, nothing else. Benadryl is an antihistamine for children and for people who are breaking out in a little rash related to exposure. And for itching, Benadryl's really good medicine. It's not a lifesaver. And so we get the EpiPens out, or what we'll call the Epi kits, and that is life-saving medicine for those patients. Wheezers. What do we do with wheezers? Well, once again, we sometimes have minutes for those patients. You go out on a difficulty breathing, young person, history of asthma, up in a tripod. Our time to go to work immediately, getting appropriate information, but setting up immediately for nebulizer treatment. The paramedics will hear that for bad wheezing, a very important first-line treatment is IM epinephrine. Part of the protocol. It is a lifesaver. We've had particularly younger people who got in trouble really quick, and they're short of breath. And what happens is they can't move enough air to make the nebulizer treatment work for them. It's not getting the albuterol deep enough into their lungs. The first treatment for asthma, so everybody knows the history, was intramuscular epinephrine. When I first started working in emergency departments a long time ago, the nurses would line up syringes of epinephrine on the bedside table, on the Mayos, and they would predict how many EPIs they thought that patient would need based on their assessment when the patient came in the door. So a patient they didn't think was very bad would have like 3 epinephrine 0.3s sitting on the Mayo stand, and their way of doing the work on the patient was listen to the patient, they're wheezing, they give the first epinephrine, the syringe is empty, they cap it, put it on the table, so that anybody else who came in to care for the patient, if they got distracted doing something else, they knew that that nurse thought it would be 3 epinephrine shots about 15 to 20 minutes apart, and that the nurse had already given one of them, so an empty sitting there. Now, this was in the older days before all of the hazards and all that, but you go in 15, 20 minutes later, listen to the patient, they're still wheezing, a second epinephrine in, the second empty goes there, the third one in 15 or 20 minutes later. That was that nurse's prediction about how many shots it would take. In other cases, they'd have 7 or 8 of them lined up, and they thought it was a more significant case that would require more epi. I want you to be aware the history of caring for asthma began with IM epinephrine. Now we are in a state where most asthma patients do really well with our albuterol nebulizer treatments, but occasionally you get a patient who's sick enough who you recognize right away is not moving air. I had a case like this recently in the emergency department. A young girl came in carrying her empty inhaler, gray. At this point she was too sick to even tripod herself. She's moving no air. So we hear no wheezing because she's not moving enough air. She was better off in a rolled over position. Epi, please, right away. Give her an injection of epinephrine, plug her into the nebulizer. The original epi shot began to work to the point where the nebulizer began to be effective. We could then sit her up and begin really effectively getting her to breathe, making sure nothing else is going on, etc. Life-saving medicine in extreme cases of asthma. Waking up diabetics. Across my career, one of my very favorite things to do. Typical stories. People don't have their food with them or get way behind and their sugar goes down. You all have your favorite wake-up lines. My favorite wake-up line was a girl in an office setting who was 8 months pregnant and went down. We have an entire office staff around us as we come in, and the office staff very concerned because they knew she was pregnant and knew she'd been having some trouble controlling her sugars. We get an IV and start to give her the medicine. Everybody's just silent, you know, watching for this to happen. And she's down and she opens her eyes and sees us in uniforms. It says, without knowing who else is around her, and says, "Did I keep my clothes on this time?" And it was just an immediate relief, and there's just hysterical laughter around. Fortunately, nobody knew what she meant by that line, but apparently had some relevance to her, and she woke up okay and did really well, and we could get her some food, which is what those patients need. They got to get some calories in their belly to keep their blood sugar up, but we all have our favorite wake-up lines with the diabetics. There are cases where rescue, extrication, triage has to be done immediately, where IV fluids given quickly are really important. Shock patients, hypovolemic patients, etc. And then down near the bottom here I list, getting electricity to a patient in cardiac arrest is the most important intervention that we do. We'll talk later about pit crew CPR. Really important if the electricity doesn't work, that we get on the chest right away and do compressions at 100 beats per minute using really good pit crew procedures, and we get the patient taken care of. But our first intervention in all cardiac arrest patients is to see if they're in a rhythm that requires electricity to turn it around, and we get them the electricity. And for some patients in our community, electricity, and it takes one shock, and you get them back with an AED or with a manual defibrillator. So that's another seconds to minutes intervention that we do that's really important, and you only get one shot at doing that. All right, medical priorities. Well, we have a county medical protocol. It contains our formula, our menu for what we do to save lives. Everybody has to know the medical protocol at the level at which they practice. We have to deliver the care according to the protocol very quickly. Airways are important. You'll hear me across my career. I talk about endotracheal intubation. For the paramedics, endotracheal intubation provides a secure airway. It provides us a way of assessing the patient more adequately. It provides protection for the patient from aspirating stomach content into their lungs. So I will always prefer endotracheal intubation and the training that it takes to keep our paramedics proficient at that. Cardiac arrest management is about pit crew, and Dennis has promised that we'll do more pit crew evaluation. I'll talk about that in a little bit. Operational priorities. What is our duty? I have defended a lot of fire EMS personnel related to issues like consent. I can be very clear that we have a set of legal priorities in the community's eyes, and they will come out in law in court if you don't remember them. Our first duty is to evaluate any patient who requests evaluation. That means when we get a call, our responsibility is to evaluate the patient that call was about and to document it. There are pieces to that, and the pieces begin with our duty to find a patient. Finding a patient means when you get a call to a certain address, it's our responsibility to go to that address, to assess the patient that we find there, and to look very clearly for where they may be. Some very famous cases, and one of them I give you is a Chicago Fire Department case. Young girl who calls 911, short of breath, gives her apartment number. The crew gets dispatched. They go to that apartment number, knock on the door, get no answer, and for whatever reason say no patient found and went back in service. The patient died, a young girl. Medical examiner found that she died the hour of the call. They can't be any more specific than that. Family, had called to look for her, didn't find her, go to her apartment, get in, she's dead. They look through her cell phone, see that she called 911. Well, what happened here? And of course they go back through the dispatch tapes and see what happened. Can't explain. And of course you have an entire huge metro fire department that feels very bad for that event because it made big media. We've had cases of auto accidents where the crew went and took care of some part of the accident, and some hours later, sometimes by the media, that was one of my cases, the guy is there shooting the scene after the red lights have all left, and the wrecker crew is there pulling the car, and the guy who's filming this for the local TV station hears moaning in the back of the van and looks inside, and there's somebody in there. Crew called back to pick up the next victim. Wrecker crews have found victims. We have had interstate auto accidents, rollover, victim inside, really nice job extricating it, transport the patient to the hospital. Next morning, somebody going by the scene, or somebody, in one case, in their backyard is another patient, died of traumatic injuries. Medical examiner says, preventable death. We have to do complete search for victims once we're called to a scene to make sure that we find any patients that there are. So our first duty is to find any patients, reasonable circumstances, but looking completely. A recent case for you all that you may have heard about was a fire case from Metro Atlanta, Georgia. Get called for smoke in the area at 3 or 4 in the morning. The crew sweeps the cul-de-sac, says nothing found, goes back in service. A couple hours later, the neighbors wake up to a house completely ablaze, and the woman at the door couldn't find her way out the door. Very famous case, and one which makes an entire department feel bad. So our duty is to respond, to find a patient, and to evaluate the patient. By the way, evaluation, we'll talk about consent later on, but we evaluate any patient that we find regardless of age and regardless if parents are there or not. Our next responsibility is any emergency condition that we find, we are responsible to treat. So that if you find a child who's with their older sibling at a park who got stung by a bee and is having a reaction to the bee sting, the older sibling notices that the 3-year-old is really sick, calls on their cell phone, says, you know, my sibling got bit and is having trouble breathing now. So you have a 3-year-old and a 16-year-old and no parents around. And the 3-year-old you've been called to assess is sick. What's our responsibility? Absolutely 100% of the time, the responsibility is to treat the child. Treat the child. You do not need the parents there to tell you that you can give emergency treatment to the child. Your responsibility is to treat any emergency condition found. If it's a non-emergency condition, you have a responsibility to get consent for the patient. So if we got a call to the park and the child, you know, fell and was bleeding, and the 16-year-old sibling can't stand the sight of blood, calls and says, "Oh, my sibling's bleeding and it's terrible and I can't do anything about it." And you go and you find the sibling who's sitting there and has a scrape, and you clean the scrape and put a Band-Aid on it, and it may or may not require stitches. You can't tell. You're not supposed to tell. The 16-year-old sibling is there with a cold, wet washcloth on her head that you put on there because she was ready to pass out because of the sight of blood. And your responsibility now is not to put stitches in the child or to make a decision. At this point, we don't have an emergency condition. We have treated the emergency, which was the bleeding. We bandaged it, and now it is up to the parents whether that child needs stitches or not. And so we wait for the parents to get there, make a decision about when and how the child goes to the hospital or to an urgent care center, and that's elective treatment. And we allow parents and others to give us permission to do that. In dealing with minors and the elderly intoxicated, consent's really important, and we'll have full lectures about consent. But I want to make you aware, if you find an emergency condition in any of those groups, it is your responsibility to treat it immediately. That's our protocol, that's the law. It says when you put the patch on, that is our responsibility. It's also our responsibility to do appropriate end-of-life care for people. And now we are fortunate to have conditions where people recognize they're reaching the end of their life, or one of their family members is, and they write a medical plan for them. And that medical plan says, when I die or when my family member dies, the medical plan does not include chest compressions, an airway, being ventilated, having IVs in, and given resuscitative drugs. That's a good medical plan for people with certain medical conditions and end-of-life care. We write that into a document, and we have it available for crews that may come and be asked to take care of the patient. So that is our do not resuscitate, physician orders for life-sustaining treatment. It's got a variety of initials. Our responsibility is to follow that plan of care that's been laid out by the patient or their family members, and that's a good plan of care. And it says don't do certain things, and that is exactly what we're supposed to do, is not do those things. All right, our next set of administrative priorities. Work professionally with all of the other agencies that we're working with. That's EMS, that's the police, that's the medical examiners, that's the co-workers, that is the mental health professionals that we work with. Make sure that everybody in our department is collaborative and providing professional services. It means we protect each other, so we don't put each other in precarious positions, or we don't put EMS in a precarious position, and we avoid getting into trouble with our own members that way. I'm a big writer about incident rehab, and in that way taking care of ourselves to make sure that that at an incident where we warn people out, where it's wet, where it's hot, where it's cold, etc., that we could take great care of our people and that we get everybody safely through the end of their shift. And so incident rehab, really important. And in circumstances like hazmat incidents, that we take care of each other, doing pre and post suit assessments. Documentation, and we're at work on the documentation element. All of the medical and administrative documentation needs to go well. We are particularly working right now on documentation for non-transports because that is so important. All right, I'm going to run quickly through a couple of patient related items that are very, very timely for us and things that are changing. Okay, so I told you 40 years ago almost, I got my EMT certification. 40 years ago, we thought every patient belonged strapped on a backboard. If you got injured, you went on a backboard. We immobilized you from head to toe, and we transported you. And I could do that in my sleep. We'd have a 2 o'clock in the morning auto accident, relatively minor, nobody trapped, no scene hazards. We could put somebody on a backboard, strap them, take them to the hospital, turn them over. The emergency department dealt with every patient coming on a backboard. And I could go back home and go to bed again, or go back to the station, go to bed again, and the next morning I wouldn't even remember what I did at 2 o'clock in the morning. So it's just kind of built into your brainstem that every patient would go on a backboard. We always knew that there were some patients that could be really dangerous with, and people that would have pressure problems, people that were too large to lay down, people that had an airway problem, that if you laid them down they couldn't protect their airway. Nonetheless, we felt an obligation to do that. Thank goodness, last 5 years we've backed off that. The surgeons have backed off that. The trauma centers have backed off of that. And now, if somebody has mild neck pain after a low-speed motor vehicle collision, we put a collar on their neck. We transport them sitting in a position of comfort, safely on a stretcher, immobilized with the stretcher's capabilities. Somebody who has fallen and has a lower back injury, we don't immobilize their neck because they don't need it. Somebody who got whacked in the posterior chest and along the T-spine with a pool cue in a bar fight or similar, we don't immobilize their neck because their neck doesn't need immobilization. We put them in a position of comfort for their injury and transport them. So we use spine immobilization when needed. We use backboards to get people out of a lot of circumstances and to lift them or to lower them safely. We get to the stretcher and say, is this tool still needed? And does a patient benefit from immobilization, laying down on a board and strapped to a board? In many cases, the answer is no. And then we safely roll them onto the stretcher. We put them in a position of comfort there and to protect any injuries that we do know have happened, and transport them safely in the vehicle that way. So spine immobilization, much less used than in the past. Appropriately, we've saved a lot of lives doing that. It is very clear there are patients that are hurt laying on a backboard. The patient who weighs too much and can't maintain their airway in a laying down position, oftentimes telling you as you got to them in an auto crash, you stick the board underneath them and they say, I can't lay down, I haven't laid down in years, I sleep sitting upright or I sleep propped up, I can't lay on a board. We have to recognize that. Sometimes they don't have much of a neck and we have to still immobilize their neck because they're complaining of neck pain. So we use towel rolls or blanket rolls around their neck. We immobilize that. We may use the board to slide them onto our stretcher, but then sitting up. We have people who are, let's say, make it easy, sports injury to the jaw. Same thing happens in a bar fight. They broke their jaw. They have a bloody mouth. When you get there, there's blood coming out of their mouth. They feel most comfortable sitting forward. You give them a container to have the blood roll into. What would happen if you tried to lay them down on a backboard? They'll die. They can't maintain an airway. If they've broken their jaw and you lay them flat on their back, their jaw can't support their tongue goes against the back of their throat. They're fighting with you, swinging at you, and they're telling you, you're killing me. And we can't kill people. That was rule number one, if you recall. And so it's really important that you recognize there are some people who can't be laid on the backboard. There are people in congestive heart failure. Can't lay them on a backboard. They can't breathe if you lay them down. So immobilization, and we'll have full basic immobilization lectures coming ahead. but making you aware that's a big change in how we've approached trauma injured patients for the last 40 to 50 years. All right, and I'm going to finish up today with what is really exciting, which is our ability to resuscitate people in cardiac arrest. So we have gone through our management of cardiac arrest. In my 40 years and about 60 years now, 50 to 60 years, we've had modern resuscitation techniques. We always knew that a patient in cardiac arrest, so a patient you find not breathing or agonal breathing with no pulse, truly no pulse, the best thing that can happen to that patient is that you can find them in a rhythm for the paramedics VFib or VTAC that is shockable. That is the very best thing that you can find in a patient with no pulse. And the treatment for them is to get electricity into their heart as quickly as possible. So with an AED or a manual defibrillator, we get them hooked up rapidly. We want to find VFib or VTAC and want to deliver the first shock as rapidly as possible. That's what we want to find. If there's any delay in being able to hook up the defibrillator, then we begin our resuscitation by doing chest compressions. What is the correct rhythm for chest compressions? 100 beats a minute in all age groups. And it's to the rhythm of Staying Alive or Another One Bites the Dust. Both of them are 100 beats per minute cadence. We don't do 140 beats per minute because it's not better, it's worse. We don't do 60 compressions a minute, that's worse also. 100 compressions a minute. We put oxygen on their face, and even passive oxygen assists them a little bit, or bagging them slowly, asynchronous with the person doing chest compressions. Our brethren in NASCAR country developed the idea that there are three people most important to the cardiac arrest patient: the person doing compressions, the person managing the electricity, and the person who's managing the airway and a little bit of breathing or oxygen. They developed this into what they called pit crew CPR, so that one person in a cardiac arrest situation at a BLS level, so this is about a 3-person BLS crew who initiates the resuscitation, and then as further crew members arrive and as ALS providers get there, they work around this basic 3-person crew. And that 3-person crew looks like the pit crew in a NASCAR race. They move very efficiently in rotating positions and responsibilities: compressions, electricity with the AED, and maintaining the airway, and applying oxygen, and then bagging as necessary. So that is the adult patient approach to out-of-hospital cardiac arrest. Begins with a 3-person BLS crew, one of them on the chest, not losing their rhythm and never giving up, and at about 200 compression intervals it rotates through, and if necessary they rotate the positions or responsibilities. A person managing the airway. Now what we have found is that endotracheal intubation right away does not help cardiac arrest patients. We've also found that bagging them quickly does not help. As a matter of fact, bagging too quickly and too forcefully fills the lungs with air, and then blood can't get into the heart. So we've moved towards slower breathing rates, and where bag valve mask isn't available at the time, just passive delivery of oxygen. So you put a mask on at 10 liters, 15 liters, and it is passively sucked in when someone is doing chest compressions. And then, as I said before, very important that we get pads on and deliver electricity if the AED tells us that electricity is needed. If a shock is not indicated, the machine tells you that, then it's chest compressions, bagging at a slow rate, and application of oxygen, making sure that the patient doesn't vomit and aspirate. And that third person is waiting to do compressions. Or syncing the AED so that in 5 minutes it's ready and that individual is ready to go off of the second analysis of the patient. ALS providers arrive, and their job then assess the airway, set up for manual defibrillation, start an IV or an IO. administer some of the medicines that don't have as good of effects as the BLS pit crew doing compressions, electricity, and the airway. So we'll go over pit crew CPR. It's a really good company drill to do to keep everybody up to date. And in organizations and departments that do it well, it dramatically increases their resuscitation rates. That's good outcome for the patient. It also is good outcome for the patient's brain. So it's not just heart resuscitation, it's brain resuscitation. I was just at a couple meetings where we talked about further improvements in CPR and stuff that we may talk about in the coming months. And one of those things actually involves slightly raising the head of the patient, because raising the head of the patient, or what's called heads-up CPR, allows them to drain blood, old blood, out of their brain so that fresh blood can be moved into their brain with the compressions that are going on. That involves brain resuscitation in out-of-hospital cardiac arrest. So there are some new elements to this that we may add, some new tools to make our job easier, and better outcomes for the patients is the outcome. That is enough for my introduction to all of you. I am very much thrilled to be working with the department and our opportunity to serve our community better, the community where I live. So I'm available. I'm in the department's email system. I have a phone that works 24 hours a day, 365 days a year. My other departments use it regularly, and I thank you for the opportunity to serve with you, and I'll see you in about a month. Thank you.